Welcome to Cardiovascular Innovations Going Digital in 2020. My name is Eric Scott, and I'm a vascular and endovascular surgeon at the Iowa Clinic in Des Moines, Iowa. And I was asked to present a case on hybrid approach to multi-level CLI. Now, when we think of CLI interventions, I think many of us think of below-the-knee interventions. We think of pedal interventions now more these days. But it's important to point out that CLI usually means multi-level disease. In this publication by Chung and colleagues, published in the Journal of Vascular Surgery several years ago, they looked at the distribution of hemodynamically significant stenoses in patients with critical ischemia, and they found that patients with only infrapopliteal lesions accounted for only 11 to 29% of the cohort. The most common distribution of lesions, however, in patients with CLI were patients who had disease at all infralinguinal levels, ranging from 35% to 51%. And if you took the question one step further and asked how many patients with CLI actually have disease virtually everywhere, that would be aortoiliac, femoral popliteal, and below the knee, the percentile ranged from 13 to 17%. So the case I've chosen to present to you today is that of a 66-year-old male with obvious gangrene of his right foot who presented with two discrete levels of occlusive disease. His past medical history was significant for known peripheral arterial disease, some reflux depression. He was an aggressive smoker at 1 to 3 packs per day, and he already had multiple vascular interventions, including a bilateral carotid endarterectomy as well as a left femoral endarterectomy. In workup of his previous left lower extremity ischemia, he'd had an angiogram in the right groin with a sheath you can see inserted here just above what is clearly an occlusion of his mid to distal right common femoral artery. And then more recently, for his ischemia now in the right lower extremity, he'd undergone a duplex ultrasound that confirmed or showed once again his right common femoral occlusion, as well as a high-grade stenosis in the popliteal artery. His ankle brachial index at this time was 0.46. Knowing this gentleman was headed towards a right femoral endarterectomy, I elected to defer formal angiography in preference for non-invasive imaging. So I performed a CT angiogram. It confirmed the occlusion of his mid to distal common femoral artery. It did not as well show his popliteal stenosis. As you can see, it's hidden in calcification lesions in the vicinity of the P1 and 2 segments. You also have some indication he's got significant tibial disease involving the anterior tibial and the peroneal artery at the least. So in this clinical scenario, with extensive gangrene of the right foot and a right common femoral artery occlusion, at the age of 66, I felt like he was best suited for treatment of this lesion via open surgical endarterectomy, but I also realized almost the entire extent of his SFA was widely patent, and he simply had a critical stenosis within the popliteal artery. So my choices to deal with that lesion were either a below-the-knee popliteal bypass for a focal lesion or to treat this in an endovascular fashion. And so now you begin to see how I felt like this case was actually a perfect case for hybrid revascularization. So the plan would be a femoral endarterectomy and greater saphenous vein patch angioplasty, as that saphenous vein was not suitable for bypass anyway. Step 2 then, in the same operation, would be an endovascular treatment of his critical right popliteal stenosis, and then this would ultimately be followed by what I thought would be a transmetatarsal amputation. We proceeded to a hybrid operating room, and in the span of about an hour, we're able to perform an extensive right common femoral endarterectomy. We extended this endarterectomy onto the proximal SFA, and then we harvested that proximal greater saphenous vein for patch angioplasty, the completion of picture of which you can see on the left. We immediately then followed that with a completion arteriogram that you can see on the right. The advantage of femoral endarterectomy, quite simply, is that you can get all the plaque out. So the picture on the left here is the specimen removed from his common femoral artery. And we know from published data that femoral endarterectomy yields some of the highest patency of any of the procedures we can offer, with 91% 5-year primary patency reported. Once the femoral endarterectomy and patch angioplasty were completed, I then used the imaging capability within the hybrid operating room to perform a completion arteriogram of the entire right lower extremity. In contrast to the CT angiogram, you can now very clearly see the very high-grade stenosis in the P2 segment of the popliteal artery, and better get a sense of the tibioperoneal runoff, where the posterior tibial artery is clearly the predominant inflow to the gentleman's foot. Now for high-grade, heavily calcified popliteal lesions like this, my go-to treatment is usually directional atherectomy and balloon angioplasty. I do this because you can use a filter basket distal to the popliteal lesion, and with directional atherectomy you can make repeated cuts to get the lumen gain that you want. And so in a case like this where I'm trying to minimize the stent risk, I think directional atherectomy and its ability to be used or titrated to effect, i.e. lumen gain, can be a nice way to tackle difficult lesions like this. So using a TurboHawk LSC and a 6mm spider embolic protection filter, I was able to make multiple cuts directed at this lesion, with more cuts directed in the medial direction where the preponderance of plaque was, and got excellent lumen gain after several minutes of targeted atherectomy. I then proceeded with balloon angioplasty of the lesion using a 5mm angioplasty balloon. This was a case performed in 2015 before I had access to drug-coated angioplasty balloons. I wanted to provide a case with long-term follow-up. Nowadays, I would use drug-coated angioplasty balloons for this, and you can see on the image on the right, we got a beautiful result using the combination of those two therapies. So after a successful hybrid operation in the right lower extremity, the gentleman shortly thereafter underwent a transmetatarsal amputation and really had no postoperative complications. At 4 months, his transmetatarsal amputation was well healed, and duplex ultrasound at this time demonstrated normal flow velocities in the common femoral artery and the popliteal artery. His ankle brachial index was 0.96. And I chose this case for long-term follow-up because he is now 5 years out from this, has required no secondary interventions, has had no real concerns in the extremity, and he remains fully mobile with his transmetatarsal amputation. In concluding this case presentation, I would encourage you to pursue the hybrid approach when you think it's the best thing for your patient, even if it means asking a surgeon for help. As a vascular surgeon, I think these are the types of cases that are great for collaboration amongst different specialists. And it's great not only for our collaboration, but it's often the best treatment plan for our patients. And ultimately, that's what matters the most. Thank you for your attention.